Thank you very much for that very kind, glowing introduction. Those slips were deliberate to try and make me look better. Okay, so thank you, David, for that great introduction, and I'd like to thank the Conference Scientific Committee for inviting me to give this talk. So I'm going to talk today about implementation intentions as theory delivery devices. Before we get to that point, I want to skip over a couple of quite larger points, but hopefully I'm speaking to an audience that's broadly on the same page. So I want to talk about why behaviour change is important. Don't worry, that's a single slide. That using theory to inform interventions is a good idea. That's, I think, 2 slides. Then there's 70-odd slides on implementation intentions as, yes, Paul didn't mention the boredom alarm. There is no way out of here, guarding the door. So I'm going to talk about implementation intentions as one possible means of delivering behaviour change techniques. So I'm guessing that people I'm guessing that people will have come across implementation intentions at some point, and it's my view that actually their use has been relatively narrow. And I want to talk about the broader ways, the broader means by which we can use implementation intentions to deliver all kinds of different kind of intervention. And then I'm going to draw some conclusions if anybody's still awake by then. Before I sort of go galloping off through these slides, and apologies for people who suffer from strobing, I've got too many acknowledgements to make. So what I wanted to do is, rather than miss a load of people out, you'll see names pop up as we go through the talk, but I specifically wanted to thank Maddie Arden, Mark Connor and Paul Norman, who've been and continue to be valued colleagues, the various institutions at which I've worked or studied, and the various people that have funded this research. So the first point I want to make really is that behaviour change is important. And depending on who you read, who you believe, who you trust, up to about 70% of mortality is caused by behaviour of one kind or another. So we can think about things like smoking, excess alcohol consumption and a healthy diet, but arguably there are broader behaviours, broader attitudes such as medical decisions and policy decisions, all of which contribute to mortality, which I'm hoping people will agree is a good thing to avoid. Second point. I think using theory is a good idea, and as a health psychologist, of course, this is really our bread and butter, isn't it? So one place to look about how to change people's health behaviour is to look at the NHS website. And if you look at the health coaching for behaviour change programmes, they make 2 broad points. One is that they are aiming to improve patient experience and satisfaction. Now, there's a whole other talk on this that I'm not really going to go into, but I haven't seen the data that shows that patient experience and satisfaction is related to mortality or morbidity in any kind of way. But let's leave that until later. What I want to focus on is this second point, which is to do with motivating patients to self-manage. And this is the whole core of what I'm going to talk about today. So if the NHS wants us to motivate patients to self-manage, begs the question, well, how motivated are these populations to start with? And actually it turns out that people are pretty motivated. If you look at representative surveys, loads of smokers want to quit, loads of people want to lose weight, and these are not people seeking treatment, these are just people out there in the environment. So if we want to motivate people to self-manage, is it really worth doing it? Are we looking at the right end of the problem? So if you ask people how motivated they are, and I must confess, I was planning to do this with all the studies we've ever done, and in the end, I narrowed it down to 2. But these are pretty illustrative of what we find. We ask people, how motivated are you to lose weight, to eat more fruit, to be more physically active, to quit smoking? And what you find is that people report being fairly motivated. So these 2 bar charts show you the extent to which people are motivated in blue, and the red bits are the scope for boosting motivation further. And I hope people will agree that actually trying to motivate people further might be counterproductive, or certainly it seems to be the wrong end of the problem to me. So populations are motivated, individuals seem to be motivated, and as I say, we find this across most of the studies that we've ever done. So there's this paradox. People are motivated to change. People tell us that they know how to make these changes. So it seems that there's something beyond motivation. Of course, people will recognise I'm leading you down the path of talking about volitional processes. So this apparent disconnect between people being incredibly motivated, telling us that they're incredibly motivated, and failing to act seems to be the key point at which to intervene to bring about public health change. And this is consistent with various theories that posit a distinction between motivational processes on the one hand and volitional processes on the other hand. And what I'm dealing with today is bridging this gap between people's motivation on the one hand and their actual behaviour on the other hand. Okay? So the core technique that I'm going to talk about is implementation intentions. So I'm assuming that some people will be familiar with implementation intentions, but for the uninitiated, implementation intentions are very specific kinds of plans. We know they're very specific because if you just ask people to make plans, they don't work. Whereas if you get people to form implementation intentions, we find consistently that it brings about significant, sustained changes in people's behaviour. So implementation intentions are if-then plans. According to a vast amount of laboratory research, specifying an if, a critical situation, makes it more salient in the environment. It physically increases people's speed of responding by specifying an if. Linking it to a then gives you an instruction, something to do when you encounter that stimulus in the environment. And what we know from laboratory research is that linking ifs with thens leads to an automatic response. So the instruction that you've given yourself earlier will pop to mind automatically out of the environment. And by the environment, I mean it in the broadest possible sense. It could be a red chair, it could be an internal state such as anxiety or threat. But these cues lead to these instructions to act. So, concrete example of this. Like most humans, I'm a creature of habit. And so when I go to work or when I perform a task routinely, what I quite often do is do it relatively mindlessly. So posting a letter, for example, might be a new task that I need to do, and quite often I'll just walk past the post box. However, I find that if I form an implementation intention, then I'm able to disrupt that habit and actually perform the target behaviour. So every so often on my way to work, I need to buy something, but it happens once out of 365 days a year. So what typically happens is I go past the store where I want to buy something, in this example, plant pots. It's a relatively neutral example. I sail past it and end up having to retrace my steps or go out at lunchtime and buy these plant pots. However, if I specify a critical situation, if I'm walking past the general store, and link it to an appropriate response, namely buying a plant pot in this example, then I find I'm much more likely to do it. So here's the scene, and I've taken this from Pickering, so not far down the road in North Yorkshire. Here's the general store on the left-hand side. If I cue that, if I specify that as a critical situation, then I'm much more likely to perform the wanted response or the instruction that I've given myself earlier, namely to buy plant pots. So I'm going to present a bunch of studies. I kept adding things into this, so I haven't actually counted how many studies. There's no sweepstake on this. It was just accidental, and I might have to flip through some of them later. Although there's no clock in here, so maybe I don't. So I'm not going to go into huge amounts of detail about the measures that we took or the designs that we used or the populations that we used. I'll just signpost things here, there, and everywhere. If you want to ask questions about specific details, then please do feel to ask at the end. All I want to do is give broad brushstrokes about the kind of studies I'm talking about. So we use broadly representative general population or at-risk samples. We don't use students. We randomise people to conditions, obviously. We use intention to treat analysis. So people drop out, we assume that they haven't changed over time. We conduct a unique test of implementation intentions, so it's purely implementation intention versus nothing. The effects, as I've mentioned before, are not simply planning. These are very specific kinds of plans that need to be formulated in a specific kind of way. And we deliver them at arm's length. So, for example, in the old days when you got paper pay slips, we might staple questionnaires to it, and embedded within the questionnaires would be implementation intention instructions. Similarly, we've done them online. You can send them by text message, but we do it at arm's length. The rationale being that if it works at arm's length, could they be boosted, or could the effects be made larger by having some sort of counselling or feedback, delivered face to face? So the first study I want to talk about is actually the first study that we did on implementation intentions. In some respects, the sort of prototypical kind of study. These were, this is a study conducted in office workers. We literally stapled the questionnaires to the pay slips. You can't do that now, or certainly you can't at Manchester anyway. And the experimental group received implementation intention instructions, the control group didn't, and we wanted to see whether we were able to reduce people's fat consumption over time. So we followed these people up over several weeks. And this is the pattern of findings. Basically, in the control condition, there's no change over time. In the experimental condition, fat intake significantly decreased. There's no difference at baseline, quite a large difference at follow-up. Second one, I'm mentioning, again, gratuitous reference to Yorkshire. So here's North Yorkshire here. This is a study that we did with North Yorkshire County Council. You can see where York is in the middle of there, and I was born here. Right. Now, what people probably don't know about North Yorkshire is it's relatively rural. So if you have a look down here where I was born, lots and lots and lots of roads. North Yorkshire here, we're here, very, very few roads. So actually, driving cars is a big deal here. You know, it's quite a rural population, and getting around is actually quite difficult. When we were conducting the research, we noticed quite a few people had pictures on their desks at work. So we interviewed people at their desks in work. And it's not a significant effect, but a staggeringly large number of people had pictures of 4x4s on their desk. You know, some people have family members or animals, favoured pets. 4x4s. It's not significant. It was just salient. Okay. But using implementation intentions, even with a population as wedded to 4x4s as the good people of North Yorkshire, we're able to significantly reduce single occupancy car use. So recall, these are just questionnaires. These are self-generated, self-completion tasks, take fewer than 5 minutes to do. We fling them out at people in questionnaires. We ask them, what was the point of the study? Every single time they say, oh, these multiple item measures you're using, you're just asking me the same old questions over and over again. You psychologists are always trying to trick us. They seem not to notice that, please, we want you to plan to do X, Y, and Z, but that's what happens. These self-generated implementation intentions are capable of changing people's behaviour. But that, in my opinion, only gets you so far. What makes a good implementation intention? And we spent a lot of time scratching our heads about this, because when you code people's implementation intentions, all sorts of not gibberish emerges, but all kinds of things come out. So people think of very, very specific critical situations that are so idiosyncratic that you couldn't put it on a mug or a T-shirt or a fridge magnet or however you want to deploy it. So it takes you up a garden path. So we have this self-completion exercise that seems to work, but beyond these self-completion instructions, there's very little else you can do about it. There's very little you can sort of contribute to theory or ideas of behaviour change. So, and a related issue is, well, what happens if people sort of form the wrong kind of implementation intention? So we know, for example, that people quite often have or say that they're going to perform compensatory health behaviours. So to make up for the sticky bun that you had, you'll go for a run tomorrow. Of course, nobody does that. But giving people self-completion instructions for implementation intentions almost cues them up to engage in these compensatory health behaviours that we've identified in other related work, but that I'm not going to talk about today. So the big question is, what should a good implementation intention contain? And this is where the work's been heading over a number of years. And actually, relatively little attention has been paid to what the content of an implementation intention might be. I mean, so we have implementation intentions that help to initiate behaviour, or action plans as they're termed. We have implementation intentions that are supposed to sustain behaviour change, or coping plans. But beyond these broad sort of spheres of influence, there's content, the actual meat in the implementation intention sandwich. I'm not sure I mean that. Can we edit that later? Has been given relatively little thought. What we need to know is more about how we get people to initiate and sustain their behaviour, but also what else implementation intentions might do. So implementation intentions are simply tools. They link in a critical situation with an appropriate response. And as I said, the critical situation could be anything. It could be an emotion, it could be a fridge magnet, it could be any kind of stimulus in the environment. And the appropriate response could be affective, behavioural, cognitive, almost any kind of response. So there must be other things that we can do with implementation intentions. And what I want to argue is that implementation intentions are one form of delivery device. In other words, they're a tool that we can use to deliver different kinds of theory. So by delivery device, we have pills, we have injections that we give people, we have syringes that we give people. The active ingredient is the drug that you put into the syringe. And my argument is that our active ingredients are behaviour change techniques, or they're elements of theory, and that we can best deliver them, or at least one way of delivering them, is using the medium of implementation intentions. Again, a concrete example of this. So if you look at the literature, self-monitoring comes out consistently as one of those behaviour change techniques that seems to work across lots and lots of different kinds of domains. So in smoking, physical activity, all sorts of things. And so we tried to look at self-monitoring as a technique. So what we did was we said, lovely participants, please self-monitor for us. And what we found was that fewer than 10% of people actually did so. So for the people that self-monitor, self-monitoring seems to be an effective behaviour change technique, but actually there's a question of, well, how do we get people to self-monitor in the first place? And you can apply this kind of logic to all sorts of things. I mean, you can develop smartphone apps to change people's behaviour, but actually, if people don't download them and actually interact with them, then your perfect app is not really going to work. So what I see implementation intentions are as ways to implement behaviour change techniques or elements of theory. And I'm going to talk today about 3 strands of research that's based on self-determination theory, self-affirmation theory, and on the Transtheoretical Model. So I'll start with sort of the self-determination theory stuff. So economic incentives generally seem to be quite successful at changing people's behaviour. So getting people to make deposits and then collect rewards as they lose weight, or paid incentives to quit smoking, those kinds of things seem to work. But there are a few limitations of the approach around, sometimes they can be inappropriate depending on the state of the economy, and various ethics committees sometimes have a problem with them. They can be difficult to administer. We had all kinds of fun in a recent weight loss plan where we were trying to work out how to get the university to make cash payments to people who deposited their own money. And the administrative logistics of that were incredibly difficult to overcome. And from a theoretical perspective, they can be threatening to intrinsic motivation. The idea being that if people are motivated already to quit smoking or to exercise more, then actually paying them to do this transfers the motivation to the extrinsic. In other words, as soon as you remove the financial payments, or however you administer it, as soon as you remove those, then people stop in the process of behaviour change. So there are a few possible problems. So one way around this is to get people to self-incentivise. And in other words, explicitly tell people to reward themselves once they've engaged in a behaviour. So if you've quit smoking for a month, then give yourself a treat, whether it's a bath or invite friends around, or maybe you'd want to do it on a weekly basis. Self-incentivise, so it's people doing it for themselves. But according to the literature, they had a similar problem with self-incentives as you get with self-monitoring. In other words, people are either reluctant or unwilling to self-incentivise. So either people forget to do it, or and if you talk to people about it, people say, oh yeah, I can see that would work, I can see that would work. But they don't actually get around to doing it. And of course, implementation intentions are one way of ensuring people that will act in a certain way. So the problem, could it be of implementation? So we did a study to try and encourage people to self-incentivise. So we came up with this self-incentivizing implementation intention. It needs a better acronym. And we conducted the study in Romania, which is has the lowest GDP in the EU. So the idea of a government programme around paying people to lose weight, or any of these incentive programmes, probably not appropriate. And our sample were adolescents, and we simply randomised them to a control condition or to our self-incentivizing implementation intention condition. And this study was about fruit intake. And what we got over a period of time were significant differences in fruit intake. So we were able to boost fruit intake by approximately 1 portion per day using this self-incentivizing implementation intention. So we're at the beginning of this kind of program of work, but it seems like a good way of getting people to self-incentivize. I think there are a few arguments that self-incentives have got great potential as a behavior change technique, but the argument is that finding a way of getting people to deploy those self-incentives is incredibly important. And I just flag up one of my PhD students, Emma Brown, is got a poster in the Works in Progress section that describes the program of work that we're undertaking at the moment. So the question then arises as to what other techniques could be deployed using implementation intentions. So the next thing I want to talk about is self-affirmation theory. So self-affirmation theory is a theory about people's reaction to health risk messages. And the argument goes that getting a health risk message as a smoker or somebody who's overweight is inherently threatening. And what self-affirmation does is it gives you a way over that. It helps you process that message much better. In other words, it's a way of reminding people that they're a moral, adaptable kind of person, and it makes them much better able to cope with whatever threatening message you're giving them. And the idea is that by affirming in a domain other than that targeted, helps diminish these threat reactions, which tend to destabilize the message, which leads you to derogate the message, which leads you to ignore the message effectively. Now, the problem with self-affirmation, or one of the problems with self-affirmation, is that its base is in experimental social psychology, which has got a great tradition of recruiting undergraduate American psychology students who are quite willing to complete essays about values that they hold dear to themselves, that they're quite able to trick people with bogus feedback. So bogus feedback, you get people to fill in a questionnaire and you use that as you give them false feedback, and that's a way of affirming them and getting them to reinforce their own values. Or we get people to fill in kindness questionnaires, so a 10-item questionnaire that's rigged so that people primed with the value of kindness. So another York link here. Once did a study in the night shift of a sweet packing factory just on the outskirts of York. And I tell you, they weren't terribly keen to write essays about their personal values. I'll just leave it at that. So, is there a better way of getting people to self-affirm? The other goal of the research was that because it's sort of all laboratory-based, or a lot of this kind of research is laboratory-based, very few studies have shown actual effects on behaviour change, although there's stuff that's beginning to emerge showing sustained effects on biological outcomes in this particular study that might be worth you chasing up if you're interested. So for this particular study, we randomised people to various conditions. These are people, a major retailer, and this was a study about trying to reduce alcohol consumption. And what we did was we got them to complete a self-affirming implementation intention or a control questionnaire. So our self-affirming implementation intention was incredibly brief. If you look at the red writing at the bottom, this is one example. We gave people a choice of 4. They write out this self-affirming implementation intention and then hand it in. Okay? Control condition, don't get these instructions. This is a lot shorter than a 10-item kindness questionnaire. It's a lot less faffy than trying to set up bogus feedback and leaving coins in telephones that people no longer use anymore anyway. So why is that? So incredibly brief, but a potentially important way of deploying self-affirmation, because again you can embed it in a questionnaire. It's relatively subtle, and again we find that people don't report that they understand what the process is. So this is the kind of information that we give them. So these are people who regularly consume alcohol. We give them information about the bits of the body that fall off if you drink too much alcohol. Here's a diagram here. Everybody gets the same kind of information. One group gets the self-affirming implementation intention. The other group doesn't. And what we find is that, as we predict, people who self-affirm are more accepting of the message. So we take a surreptitious measure of whether people actually take the information that we give them away with them. So we have this objective message acceptance. People take this stuff away with them, more so in the experimental condition than the control condition. We're also able to significantly boost people's motivation. So we significantly affect people's intentions to drink less alcohol. And we significantly reduce the amount of alcohol that's consumed. And in this particular study, we're reducing alcohol consumption by approximately 1 unit per day, which in public health terms could have a massive benefit if done on a wider scale. That study was in adults. This one we were able to replicate in adolescents as well. So this stuff works not just in adults, but in adolescents. And of course, if we want to intervene to change people's health behaviour, it seems sensible to try and start as early as possible. Of course, adolescents drink less than adults, but we're able to still get this significant effect of about half a unit per day. What we've also done recently is that expansion bit that I was talking about at the beginning, which is, well, implementation intentions can be used to affect other kinds of thoughts, feelings, not just behaviours. So what we did was we used the self-affirming implementation intention to see whether we could affect people's subjective well-being. So if you recall, the implementation intention is around feeling threatened or anxious, which people might do in a range of different kinds of situations, and then remembering values that are important to yourself is the appropriate response. And what we're able to do over time is show significant boost to subjective well-being, and these are the ONS well-being measures that are used in national data. So not just about changing people's behaviour in terms of smoking cessation or alcohol consumption, but also about improving people's subjective well-being, which of course is also an important public health goal. So implementation intentions seem a good way of delivering self-affirmation, seem a good way of delivering self-incentives, and what we find is that we get the marginally superior effects to the standard self-affirmation manipulations. So again, a flag for a presentation that's taking place this afternoon. Charlotte Garrett, one of my colleagues, is presenting on some work that we've been doing in relation to long-term conditions, multimorbidity. And what was interesting was that, actually, no, Charlotte's giving the talk. You have to find out what's interesting about the talk, but it is very interesting anyway. We're also doing some work with University of Manchester students, deploying the self-affirming implementation intention as a way of coping with threatening or anxiety-provoking situations. So, you know, in a couple of years, hopefully we'll get some data from that. So, what other theories? Well, slight hobby horse of mine is a Transtheoretical Model. People don't like the stages. People throw things very cross about the stages. I like the bit in the original book where he talks about him and his wife discussing which of their friends they'd like to have sex with. But I don't. I truly believe I'm the only person that's actually read this book because it's hilarious. Nobody knows that bit, do they? They kind of know the stages and go, oh yeah, right. Okay, so Transtheoretical Model, which looks like this, or that, or that, or that, or that. Apologies for the strobing. The point being that I'm not too worried about the stages of change. You know, that's all very well and good. What I'm interested in is that Jim Petreska actually went to the trouble of going through 20-odd, 30-odd different modes of psychotherapy to try and extract some principles of behaviour change that he labelled the processes of change, and which in the original model are described as independent variables. In other words, variables that you should manipulate, with apologies for the condescending Sci 101 bit just there. We also have a concept, you know, very familiar to people of self-efficacy around temptation. And in my mind, temptations are critical situations. Temptations, you know, and most of the Transtheoretical Model is around smoking, but temptations such as being happy, being sad, being anxious, being excited, being stressed, being in a certain time and place, these are all critical situations. But helpfully, we also get appropriate responses as well, which is around seeking out help from other people. It's around going for a run, substitution behaviour, a whole raft of different solutions to these potential problems, which we developed and condensed into what we've called the Volitional help sheet, which is... One weekend, when I was working on this many, many years ago, I took an old piece of equipment up into the loft and thought, aha, nobody's ever going to use a VHS anymore. And I thought, ooh, VHS, that's an acronym going begging. As colleagues from Manchester know, I am the worst acronym generator in the world. And this is the one and only time I've come up with a decent acronym, and it was someone else's, and it was entirely accidental. So we called it the Volitional help sheet because we used to have a VHS recorder, and I had to put it in the loft. But it probably still is, to be honest. But what the Volitional Help Sheet is based on are published scales, so stuff that's already out there, published scales on temptations and processes of change. And what we get people to do is to link together critical situations or temptations with appropriate responses or processes of change. So if I'm tempted to smoke when I'm desiring a cigarette, then I will think about something else. And what we give people is a Volitional Help Sheet, and we get people literally to draw a line linking together critical situations with appropriate responses. So they literally draw a line. In our control condition, we just get them to identify critical situations and appropriate responses. So the two conditions are incredibly closely matched. It's that simple drawing a line or simply ticking. That's the critical difference. So what happens? If you give people no instructions, nothing happens. Smokers filling in questionnaires don't quit if you give them a questionnaire. If you ask them to plan to quit, you get this 2% quit rate. So, a few people quit, and that's about the equivalent of a GP telling you to quit smoking. But what we get with our Volitional Help Sheet is this 19% quit rate. So we get this marked jump in quit rates, and admittedly, these are 4-week quit rates, but that's what the NHS uses to determine its targets. But we get these quit rates using implementation intentions as a way of delivering concepts from the Transtheoretical Model. And we've developed Volitional Help Sheets for a range of different kinds of behaviours. So actually, the talk is very nearly at an end, so you can all breathe a sigh of relief. So I just want to take you very quickly through some of the research that we've been doing around the Volitional Help Sheet. All this stuff is based on published scales. A lot of work's gone into these scales, and we're repurposing them to try and deliver these Transtheoretical Model constructs. So this is alcohol consumption, and again, we're reducing alcohol consumption by about 2 units per day in the experimental condition compared to the control condition. In terms of binge drinking, I think this is the one example that I've got where we did recruit students, but again, we get this significant, substantial effect on binge drinking. We recently looked at smokers. Smokers are an interesting group because people assume that smokers are way beyond helping, so don't try and help smokers. But we recruited, and there are lots of interesting brain mechanisms around reward as well, which makes smokers an interesting test bed. But we're able to reduce the alcohol consumption of smokers. Gratuitous cute slide. Fruit intake, this is an interesting population. These are hospital workers. Again, one of these groups of people who say, look, we really, really want to eat more fruit, we want to eat more healthily, but actually I don't either have the time or I forget to do it. And again, this is a population that we're able to boost fruit intake with using these Volitional Help Sheets to boost fruit intake. Ooh, that did work. I could watch that for hours, and possibly already have. That's my son Seth, is that. He absolutely loves this. Right, sorry, moving on anyway. So physical activity. So this is physical activity. We're able to boost physical activity in the experimental group. Again, this is an interesting population because a low socioeconomic status group, so it doesn't just work in middle-class people. It seems to work in all kinds of different diverse groups. This one is in, again, these are people at work, people in offices say they want to be more physically active, but forget to do so or can't schedule, or those other kinds of things. Emotional eating. So this emotional eating is an interesting one because it's the root of both obesity and eating disorders as well. So trying to tackle emotional eating is a really important one. So using a Volitional Help Sheet, we're able to significantly reduce emotional eating. So that's eating in response to very strong emotions. So again, different kind of flavour to the kind of, let's get people to quit smoking. But again, very important outcome potentially. This one, the academic world really resistant to this study, and it's one of my favourite ones. So I can't tell you how this paper was rejected by 14 different journals, I think. So on the 15th occasion, it finally got in. People really hate it. all we did was we recruited people in a commercial weight loss program. We didn't name who the commercial weight loss program was, and we randomized them to volitional help sheet, no volitional help sheet, and significantly boosted weight loss over and above all the things that were going in the weight loss program, which I thought, what a robust test of what we've developed, but for some reason reviewers absolutely hated it. Quite unbelievable in my opinion. So what we're able to do was, and these people are getting goal setting, feedback, self-monitoring, they're being laughed at if they don't lose sufficient weight, and that's not a joke. There's one group that we visited where they had what they called the pigsty. Honestly, this is just where there was chair. It wasn't literally a pigsty. There was no mud, there were no feces. A corral of chairs for the women that hadn't lost weight, where women were oinked at. And then you look at the British Dietetic Association, and for weeks on their website, it might still be there, for weeks on their website, they had a pig with a tape measure around its middle. So there was some mixed messages. But anyway, despite all the horrible things that go on in these weight loss groups, we were able to boost the amount of weight loss. And we've recently been able to replicate this over a much longer period of time. One possible reason why the reviewers didn't like it, but we were able to boost weight loss over a 6-month period, again, using a volitional help sheet, but in groups that are already receiving quite significant treatment. We were also able to do it in relation to self-harm. Again, some people would argue this isn't health psychology. I very much would, but we were able to significantly reduce suicidal ideation and behaviour in a sample of people who'd been admitted for an index episode of self-harm. So we recruited people literally at the bedside, got them to complete the volitional help sheet versus a control condition, and 6 months later, significantly reduced suicidal ideation and behaviour. Again, this is on top of all the counselling that was received as standard and all those other kinds of interventions that were ongoing. So in my opinion, these are robust, sustained effects. So I think the volitional help sheet shows promise in changing people's behaviour. And again, it's this idea of using implementation intentions to deliver key concepts from health psychology theories, from theories of behaviour change. And with the volitional help sheet, we've got ongoing work, of course, and we're trying now properly to integrate it within weight management services, both in Bolton and in the United States. I misread that as Boston then for a minute, but no, it's definitely Bolton. We've got, with Rory O'Connor, we've got a study at the moment ongoing in Scotland to reduce self-harm, funded by a Chief Scientist's Office. With Darryl O'Connor and Eamon Ferguson, we're using it as a stress management support tool. We've had some really interesting effects on stress-related eating. And with Lucy Byrne-Davis and Joe Hart and colleagues at Manchester, we're looking at it as a way of getting health professionals in Uganda to implement the guidance that they're given. So again, it's this no-do gap, this intention-behaviour gap. The training that they receive is great, but it's actually implementing those ideas on the ground that seems to be the main problem. I've talked too long already, so just to wrap up, I also want to say something about, these things work in diverse populations. They work in young kids, they work in people with low socioeconomic status groups. As I've already repeatedly said, they're not simply plans. People always say, oh, we do this stuff already, we do this stuff already. They did in the weight management clinics. Well, if this is working, clearly you're not doing it already. We find that they can be self-generated or experimenter provided, but we prefer providing people with the raw ingredients with which to form these implementation intentions, because it gives you some control over the quality of them, but gives the patient or the participant some flexibility as well. We also find that they require minimal engagement for them to work. So we don't sit down with people, we don't counsel people, we don't give feedback to people. We simply fling them out there and we still get these observed effects. How much stronger would they be if we actually sat down with people and helped them fill them out? So just to wrap up, we're currently using implementation intentions to try and deliver other behaviour change techniques, and I mentioned self-monitoring before. We're also applying implementation intentions in new domains. So we've got a project ongoing at the moment around oral hygiene in children with cleft lip and palate, building on our earlier work with kids. We're looking at audiology. It turns out that even once you've got people into hearing screening clinics, once you've given them all the kit, once you've counselled them as how to use it, a staggering proportion of hearing aids end up in a drawer. And it affects people's quality of life significantly. So we've got an ongoing project with that, as well as long-term smoking prevention among school children. That's with Mark Connor and Sarah Grogan and colleagues. And we're also looking at using new technologies as a platform. So I talked before about delivery devices, and I said that, in the old days, these would be stapled to somebody's payslip. But of course, you could turn this stuff into apps. You can put it online. And indeed, we've done that, and that works sort of ongoing, trying to reach new audiences and trying to boost our public health impact. So just to finish, I know I keep saying just to finish, but just to finish, really, I think the content of implementation intentions has received relatively little attention. I think people are familiar with the concept of implementation intentions, but I would argue that the content of them is equally important as the concept behind them. And that using psychological theories to populate them has got some positive features. So there's a level of standardization. There's the possibility to identify potential mediators. So in our self-monitoring work, we should be boosting self-monitoring as well as changing people's behaviour. And this, of course, allows us to test theory, which is incredibly important for health psychologists. And finally, implementation intentions seem to be effective at delivering change. So not just behaviour change, but in the way people think and the way people feel as well. And just to hammer the analogy home, much as syringes deliver drugs. Thank you.